Hey everyone, Dr. David Clark here. Today I'm going to walk you through another real patient case study from my office. Today I'm going to walk you through the case of a 52-year-old man. It's a very interesting situation. He was diagnosed with Hashimoto's and then he developed Graves' disease. So he had a hypothyroid condition and then now he has a hyperthyroid condition. So I'm going to walk you through that, walk you through the lab analysis, the testing, the treatment, kind of long-term follow-up. So if you have Hashimoto's and you also have hyperthyroid symptoms, or you're in the same situation, then I think you're going to find today's case very useful. All right, so if we dive into just a little more about his chief complaint. So his main reason for contacting me was, I want to know what is going on with my thyroid, because he was very confused by it. Because as I pointed out, he had Hashimoto's diagnosis, which is primarily a hypothyroid condition. And then after that, he developed Graves' disease, which is hyper. So in his mind, he's trying to figure out, what do I have? Do I have hypo? Do I have hyper? What do I do about this? And he wants to figure out how to minimize the future impact of these conditions on his health because he's 52. Now he also has joint and muscle soreness in various places, particularly his knees. He's got what he describes as brain fog, and he has fatigue. So not only does it have the Hashimoto's diagnosis and the Graves', he's got these additional symptoms. So what we're going to do is jump into his history, start looking for clues for that, and let's see what we find. Oh, and by the way, he also has difficulty losing weight. Now, you're going to wait a second. Now, with hyperthyroid, that means your thyroid's high. Shouldn't he be having trouble, losing weight? Now, meaning he has difficulty losing weight. He doesn't have difficulty because he's losing weight too much. He's having difficulty because he can't lose the weight. So let's see what that tells us. Okay, so back in September of 2013, he had his mercury amalgam fillings removed. And a few months later, he was diagnosed with hypertension. And then Hashimoto's was discovered during the workup for that, and he was prescribed the standard sort of endocrinology treatment, which is levothyroxine. Now, as you guys know, I got a lot of videos on this, but I'm going to say it again. Levothyroxine is fine if you need it, because, if you can't make thyroid hormones, then you need to be able to replace them. Hence the levothyroxine prescription, which is T4. Now the issue is that only works for a certain number of people. There's a lot of people, millions of people, that have Hashimoto's, that take Synthroid, whose TSH gets normal and their T4 is normal, but they still have a lot of symptoms. And that's because the levothyroxine doesn't really do anything for the underlying autoimmune problem that is Hashimoto's. And I have a bunch of videos, I'll link to them. But I don't want to go into all that stuff right now. I just want to kind of focus on how we went through his case here. Now, 5 years later, because he was diagnosed with Hashimoto's in 2013, 5 years later, to the day roughly, his thyroid peroxidase antibodies were 1,500. That is sky high. Now, again, I've got videos on what do these TPO antibody results mean. Well, in his case, what you know is this Hashimoto's is probably not that well controlled. The antibody levels don't always correlate with how you feel, though. So he might not be feeling terrible, but have really high antibodies. But the real danger of these antibodies being high, in my opinion, is because you can start to cross-react with thyroglobulin, if you're not already, which is the other major thing that your immune system can go after in Hashimoto's. And the other thing that maybe even is more worrisome is thyroid peroxidase antibodies themselves can attach to other tissues in your body and expand and worsen your overall autoimmune problem. I mean, there's a known syndrome you can look up. It's called the thyrogastric syndrome, and that's where thyroid peroxidase antibodies end up leading to stomach antibodies, and then pancreatic antibodies, and then cerebellum antibodies. So we don't want these antibodies to be very high. Like, we want them to be as low as we can get them, although sometimes you may never get them to normalize. You do want them to get as low as you possibly can. Now, some friends said, hey, go to this longevity center. And I have to say, they did a fairly decent job. They gave him a gluten-free diet. They said, hey, take selenium. I don't know if they told him to take the right kind or the right dose, but they're on the right track. And they gave him some adrenal support. Now, I have no idea if that was really warranted or not. But if all they did, and apparently all they did was tell him to do a gluten-free diet and selenium, I mean, that's not bad. But let's see how that worked. So, at one point, his levothyroxine had to be slightly increased because his TSH was not where the doctor wanted it to be. And that's another point. Very often, once you have Hashimoto's and you're prescribed levothyroxine or Synthroid or whatever it is, it really isn't you that's being managed and doctored. It's your TSH on your blood work. And that's why so many people with Hashimoto's have a TSH that's normal, but they still feel bad. And unfortunately, that still feel bad part gets chalked up to you're depressed or you're stressed, and it can't have anything to do with your thyroid. And as you guys know, if you watched my videos, there definitely can be a link between all those other things you're still feeling, because Hashimoto's is an inflammatory problem. So not only does it create a quantity problem with you not being able to make enough hormones, but it also loves to mess with cause a usage problem, meaning the hormone receptors in your cells get blocked. So even though you're taking the levothyroxine and your blood level says, hey, your TSH is fine, you may not be functioning like it's fine. So in August of 2022, though, this was just about 4 or 5 months before I saw him, his TSH was less than 0.01. Now that is really, really low. And the way that that works is, typically when TSH is that low, that the T4 is probably pretty high because there's a negative feedback. So what that means is the TSH is coming from the pituitary gland, and that tells the thyroid gland to make the thyroid hormones. And if there's a lot of thyroid hormones floating around, then the pituitary takes that signal and says, okay, well, we don't need to make as much TSH. That's the negative feedback. So when your TSH is less than 0.0, that's typically a hyperthyroid type situation. Maybe it's Graves' disease. So his levothyroxine was cut in half because the doctor thought, well, maybe you're just over-medicated. And good, cut the levothyroxine in half. I also want to ask, okay, well, why did the dosage change that much? So one of the clues that you guys may know about if you've been on the channel for a while is that when someone's levothyroxine level keeps having to be adjusted, especially in Hashimoto's, that's telling you their Hashimoto's is probably not well controlled, especially like if their body weight's staying the same. It means their Hashimoto's is not well controlled. So this doctor said, hey, let's cut your levothyroxine in half because maybe you're just taking too much. Okay, fair. Made an appointment to see an endocrinologist in October of 2022, just 2 months after this level of TSH. They did a thyroid ultrasound. That was normal, nothing crazy going on with that. And then in October, the TSH is still less than 0.1, even though he's taking half the levothyroxine he used to take. Now that's starting to tell us, okay, maybe you're not over-medicated. Maybe you're like 100% over-medicated. Maybe you don't need to be taking this at all. So he stopped taking levothyroxine, which is fine. Now 2 months later, it's still less than 0.01, and now his T4 is slightly above normal. So now what we're getting on lab work is we're getting a more classic hyperthyroid situation where the TSH is getting really low and the T4 is starting to creep up, even though he's not taking any thyroid hormones at all. So something is going on there, right? Starting to look very Graves' disease. So they diagnosed him with Graves' disease, which is hyperthyroid. It's an autoimmune condition, but it's different than Hashimoto's. The endocrinologist said, hey, don't do anything, and let's follow up in a few months. So we have to ask ourselves a question. He had Hashimoto's, now he has Graves' disease. How in the heck did that happen? Well, it's because Hashimoto's can transition into Graves' disease. It usually doesn't go the other way. So let me just take a quick second and explain the difference between the two conditions. Hashimoto's is an autoimmune condition that's destructive. The immune system basically targets the inside of the thyroid gland and blows up thyroid peroxidase and or thyroglobulin, so you can't make enough thyroid hormones. It's destructive. Graves' disease is different. Graves' disease is autoimmune, and the antibodies involved are what we call thyroid-stimulating immunoglobulin or thyroid-stimulating hormone receptor antibodies. And so what happens is when the antibodies, these TSH receptor antibodies, bind to the TSH receptor, they stimulate the thyroid gland to make hormones. They're not destroying anything. It's still autoimmune, but it's different than Hashimoto's. And it is known that people with Hashimoto's can transition into Graves' disease. It's also known that the antibodies that you find in Hashimoto's, you can find in people that have Graves' disease. So these TPO antibodies, these thyroid peroxidase antibodies, you can find those in people that have Graves' disease. So it gets really confusing because people with Hashimoto's can swing from hypo to hyper, meaning they can have temporary hyperthyroid symptoms that might last for a day or a week or a couple of weeks. But that's happening because their Hashimoto's is uncontrolled. The immune system, the T cells and the B cells, are recruited in and they're literally blowing up the inside of the thyroid gland, and it's dumping thyroid hormone out into the blood rather than dripping it out like it normally would. And that causes these temporary hyperthyroid symptoms. But that's how this gentleman first had Hashimoto's, then Graves'. It's a known thing that can happen. Now you still are going to look at both of them, if you're anyway, you're going to look at them both as an autoimmune problem. And what are things that we can do to analyze his immune system to know how to best support it. So let's see how we did that. So family history, just for you guys wondering, he doesn't have any known thyroid disease in his family. No one with Hashimoto's, no one with hypothyroidism, no one with Graves' disease. In fact, no one has any autoimmune disease that they know of for sure. So then you have to ask yourself, and he often did, well, how did I get this? Well, I was explaining this to somebody the other day. Essentially with autoimmune diseases, there's basically two ways you can get them. One is that you have a genetic predisposition, right? And then there's a genetic predisposition, some sort of a leaky barrier like a gut barrier or a lung barrier, and then there's a triggering event, okay? That's one way you can get an autoimmune condition like Hashimoto's or Graves'. But you can also, I call it, acquire them through infections or toxin exposure, primarily through a couple different processes that we probably don't have time to talk about, but cross reaction's a big one. You don't have to have the genetic predisposition to get an autoimmune condition, but it certainly ups the odds if you are. But this guy doesn't really have a genetic predisposition as far as we know in terms of looking at his family history, which is not common. Most of the time, someone that comes to me that has an autoimmune condition, there's some sort of autoimmune history in the family. So his diet is gluten-free. That's great. We already know that gluten cross-reacts with thyroid peroxidase antibodies a lot. So he's currently taking selenium, MCT oil, magnesium, taking a lot of stuff, multivitamin, baby aspirin, a combo formula with all that stuff in it. And I'll just tell you, this stuff down here, this is all for like blood sugar, but I don't like this berberine here, only because berberine can have an undesirable effect on his immune system. So guess what we're going to have to do? We're going to have to do a lymphocyte map, immunophenotyping, and find out what is his immune system actually doing. But first, let's get some baseline on some other things. Now, this is the pre-treatment blood work that we did. You can see that his glucose is, his fasting glucose is slightly high, but his A1C is not high. His A1C is fine. I don't think he's diabetic. I don't think he's pre-diabetic. He doesn't have any classic insulin-resistant symptoms. It just looks like that, okay? Now, I do think his magnesium is a little bit low for my purposes, and that can have something to do with carbohydrate metabolism and inflammation and blood-brain barrier. The albumin, don't really worry about that because that's only about 0.2 of a point high. The AST and the ALT, those are liver enzymes. Now, the ALT is slightly elevated, and I think you'd be hard-pressed to find anyone to really make a case for that meaning anything at this point because they're really not, that's barely elevated. About the only thing it could be cross-reaction between gluten and liver cells, but it doesn't eat gluten, so it's probably not that. So all this page is really telling us, I think, is his magnesium level is too low, and we probably should do something for that. And I don't think he's diabetic. Now that matters because even with these autoimmune conditions, you're always looking for, is there something that's driving it, that's kind of fanning the flames, right? And blood sugar instability is one of the things that can definitely do that. So his lipid panel, I'm showing you that mainly because his HDL is low and his LDL is a little bit high. We definitely need to do some things for HDL. Now, I don't talk a lot about HDL and lipids on this channel, but I see it all the time. We definitely got to do something for him for long term, right? Because he wanted to minimize future impact. Well, this is something we're seeing now that needs to get dealt with. So we're going to do some things to try to raise his HDL because it's too low. And HDL is that quote-unquote good or protective cholesterol, whereas LDL is not. And really, to be honest with you, this isn't even the best lipid panel I would do. I mean, at some point, we'll do a little bit deeper and do a much deeper lipid panel. We'll talk about that some other time. All right, so I think his HDL is too low. Now, looking at these thyroid markers, okay, look, even with me, see his homocysteine is a little too high, but even with his TSH is 0.01. That's still, he's taking no medication. It's been that low. Now, his T4 is not elevated, okay? The free T4 is not elevated. So he's getting some feedback to his pituitary gland that's saying this looks hyperthyroid, okay? Now look down here at the bottom. You can see obviously that his TPO antibodies are quite high. Now they're not 1500, but I also don't know what lab they used. An important point about looking at antibody numbers, because I know a lot of people, the public, get really interested in reducing antibody levels. I like to have them reduced too, but you can't compare one lab's TPO numbers to another lab's. They all kind of use different chemical analytical methods to do it, and you just can't compare apples to apples that way. Now his thyroglobulin antibody is quite elevated at 24. That's actually pretty high for thyroglobulin. So he's got these Hashimoto's antibodies still elevated, right? And what I mean is, he says his thyroglobulin antibody measured by Beckman-Coulter methodology. You just can't compare one lab to another unless you know they're using the exact same method. Anyway, his vitamin D is definitely too low. He's vitamin D deficient. You see that almost 100% of the time in autoimmune patients. It's part of the genetic package. Why does it matter? Because vitamin D is anti-inflammatory. It's immune regulatory. We definitely want that to be better. I skipped over this a minute ago, that homocysteine number. That's too high for me. I typically don't like that more than like 7 or 8. Why does that matter? Because homocysteine is a driver of oxidative stress. It's inflammatory, bad for your brain, bad for your blood vessels. Now that's what his thyroid panel looks like. So his TSH is still way too low, right? It still looks like it's suppressed as if he is actively hyperthyroid. But you can see that his free T4, free T3, those numbers are not high. So even though his TSH is low, he's not, I would not say he's actively hyperthyroid by definition. Now his TSH is still way too low though. And we can see that his antibodies are still way too high. So his immune system's out of whack. With that in mind, we can say that his homocysteine is too high, TSH is still low, definitely has the Hashimoto's antibodies, and he's vitamin D deficient, okay? Now, if we look at the lymphocyte map, let me just break this down real quickly. Again, this is comprehensive lymphocyte immunophenotyping. It's a way of kind of getting an immune system fingerprint, like what is his immune system actually doing? Now, his symptoms can't tell me what this is going to look like. So the real value of this information on this test is it's going to tell me, okay, yes, I know his immune system's got to be abnormal because he's got the Graves TSH numbers, he's got the TPO antibodies, but I don't know in which exact way it is, right? Let me show you. So what we'll see here is his lymphocyte percent is up, but his natural killer cells are not. So I'm not worried about him having an actual infection right now. But we do know that his immune system's got to be a little bit turned on, otherwise his lymphocytes wouldn't be elevated. Now if we look at the T cells and the B cells, kind of look at that little teeter-totter there, what we can see is that the ratio between the T and B's is low. And it's low because his B cells are definitely on the high end. So his B cells are kind of a problem. So therapeutically, I probably want to do something for that if I can. Now, if we look at the next thing, which is the CD4 and the CD8 ratio, you can see that that's high. And it's high, again, because his CD8 is a little bit low. So that ratio is imbalanced. But again, I couldn't know any of this from his symptoms or from his diagnosis of Hashimoto's or Graves. It's not going to tell me that. Now, his TH1, TH2 is obviously quite off because the TH1s are high. So therapeutically, I now know what I need to be focusing on because his T and B cell ratio is low, his CD4, CD8 ratio is high, his TH1 is high, and therefore he has a low TH1, TH2 ratio. So what are we going to do for him? Well, the treatment plan is I'm going to put him on a short-term anti-inflammatory diet that is more than just that gluten-free diet, right? Basically, what we're going to do is have him avoid these additional foods that we know cross-react with thyroid peroxidase. Now, why would we do that? Well, and what does that mean? It means that the antibodies for thyroid peroxidase can attach to certain foods. They're just very similar molecularly. And the idea that we think happens is that eating those foods can make you make more thyroid peroxidase antibodies. So basically, eating those foods can make the Hashimoto's or the TPO or whatever antibodies we're talking about can make it worse. So there's about 5 or 6 other foods that he was eating that I told him to eliminate. Now, also going to put him on an anti-inflammatory protocol. I'm not going to tell you exactly what that is. I know I'm kind of a broken record, but I don't want you guys trying to treat yourself because you don't even know if this is appropriate for you. This was based on his lymphocyte map and his history. But I also said, hey, you know, one of the things we can do to get your HDL up is you need to do some aerobic exercise. 4 to 5 times per week, walking briskly for 30 to 40 minutes. This is from a guy who's pretty sedentary, so I'm not going to have him like go get a membership at the gym where he probably is going to fail and not want to go back. I'm trying to give him some way that he can have some success and possibly, you know, get his HDL level up. So after 30 days of doing that, what do we find out? Well, he says, hey, my joint and muscle soreness is about 50% better than it was before. That's great. So something we're doing is working, right? It's either the diet and or the anti-inflammatory protocol or both. He said, I always ask people, what do you mean it's better? He said one of his knees, which is very close to needing a knee replacement, is feeling normal. Now, it doesn't mean he's not still going to need a replacement, but we know that we're doing something really good and something very noticeable. Brain fog is about 25% better, which is awesome. The fatigue, not really better yet. Okay, that's a work in progress. He gave up coffee, which he'd been drinking a lot of, and he was depending on that. So that probably has something to do with his perception of fatigue. He also says it's allergy season. He's taking allergy medication. He feels like those might be compounding factors, or confounding factors rather, to having his fatigue being improved. That's all right. Sometimes you don't need a home run. But he has lost about 12 pounds in 30 days. Now, the diet that I put him on, which is a temporary diet, it's not really calorie restricted, but men particularly tend to lose weight on it because it's a really de-inflaming sort of diet. Now, he did relate one episode of eating out at a tapas bar, and despite me giving him the instructions about what to avoid, there may have been something contaminating the food, meaning eating something he shouldn't have been. And he had some real digestive upset the next day. But beyond that, he really hasn't had any problems. The really cool thing is this is a guy who was having trouble getting rid of weight, right? And he's lost 12 pounds, which is awesome. Now we just got to help him keep it off. So what do we do now? Well, we're going to continue the supplement protocol. We're going to have him try to continue the diet as is for a few more weeks. I kind of gave him a choice that, hey, you're doing well enough. You can continue the diet as it is for a couple weeks, and then we'll reintroduce, or you can maybe start to reintroduce one or two things now. And he said, hey, you know what? I want to introduce coffee again and different types of seasonings. I said, sure. And in 3 weeks, we're going to recheck his magnesium, his comp metabolic, and his homocysteine, right? I want to see if he's absorbing the things we're giving him. And he did go on vacation, right? He had an episode where he had to do a significant amount of biking and walking on soft sand. Both of his knees were really painful and flared up. After a week after that, though, his knees have returned to about 85% of the improvement that we had last time. So this is a guy who has one knee that almost needs replacement. His knees have been a problem. He did this thing that should have been really provocative, and it was, but he's recovered from it very, very quickly, which is a good sign. Something like that normally would have taken him weeks, if not months, if ever, to recover from. Now, there was some question about whether or not mushrooms or apples might have been associated with that because he had eaten an excessive amount of apples and also reintroduced mushrooms, which I didn't know he was going to do. So he stopped the mushrooms. In an attempt to determine if he has a mushroom problem, he's going to reintroduce them using the same guidelines as before. We're not going to do a food sensitivity test and IgG test because those are a waste of time. The brain fog is still improving. Okay, cool. Now, after 2 months of treatment, right? After 2 months of treatment, what do we got? Well, we rechecked the homocysteine and the magnesium, and previously the homocysteine was 12.9, now it's 13.2. Well, it hasn't improved, has it? Well, I kind of messed up on that one. I didn't really give him anything specifically for reducing the homocysteine. We all make mistakes. That was something I left out of his treatment plan. So we're going to introduce that. With the magnesium, that was a 1.9, now it's a 2.1. That doesn't seem like a big jump, but we're talking about a 1/10 of a point scale. That actually is a good improvement, so I know he's absorbing magnesium. The liver enzymes have both normalized, which is great. Okay. The vitamin D has come up almost 20 points, which is great. I actually thought it would have come up a little bit more than that, but still it's come up. That's great. We know from the literature and my own experience over the last 20 years that vitamin D is really, 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 really important for autoimmune patients. So the homocysteine needs more help. It needs help, period, because I forgot to give it to him. Magnesium is better, and the ALT is now normal. Fantastic. Well, what do we do now? I say continue the protocol because he's still improving. Add the homocysteine support. After he reintroduces mushroom and we find out if they're a problem or not, we'll move on to additional foods. We'll follow up in about 30 days. Okay, so after 3 months of treatment, he's gone on a cruise since I last spoke to him. Okay. Mushrooms, I said, they're a problem, right? He's found out that they're a problem using the guidelines that I gave him to figure out if they were. And since returning from the cruise, he's kind of on a modified form of the diet. He's allowing the foods he'd already added back in, but he gained a few pounds on the cruise, which happens to just about everybody. And so now he's eliminating some simple carbohydrates. Overall, he says he's doing well, and he's pretty surprised at how well he's doing. So what do we do now? Well, we're going to continue the protocol, follow up in 30 days. If he's doing well in 30 days, we're probably going to remove some of the anti-inflammatory support and see does he really still need that or not. I just don't think you should take stuff forever unless you've got a pretty demonstrated need to do that. So after 4 months of treatment, he said over the past 4 to 5 days prior to that appointment, his left knee had been acting up. He's not sure if it's due to coming off those anti-inflammatories I told you about or just to activities of daily living. So I'm going to reach out to him in a couple weeks, and if his knees are doing fine, we don't need to add back those 2 anti-inflammatory supports. If they're not doing fine, we'll probably resume them and find out again if they can help. Because I want him doing as best as he can, taking the fewest things as possible. And sometimes you just got to take it away and add it back to find out. So we're going to continue the diet as he has it and his supplement protocol. Now, remember, with that diet, it was very restrictive. I didn't tell you exactly what it was. It was very restrictive. He's not eating the cross-reactive foods with thyroid peroxidase, but now we've opened it back up, and so he's adding things back because we want him to have a varied diet. But here's the thing. In 30 days, basically month 5, we're going to recheck his TSH and the thyroid antibodies, and that's where we're really going to find out, I think, are we really doing something to regulate that autoimmune thyroid problem he has, right? So after 5 months, he emailed me a week prior to this appointment and said that his knees were doing generally pretty good. Those turned out to be kind of like the dash light on the car to tell us how good we were doing in terms of the inflammatory stuff in his body. He was sore for a day when the hurricane came through. That's not a big deal. That's drops in barometric pressure. A lot of people get that. But what about the lab retest, right? Here's where we're really going to find out if we're doing a good job. So the TSH used to be 0.013. And remember, it was that way for a year and a half, right? Even with taking no levothyroxine. And now it's at a 2.1. That is about as normal a TSH as you can get. He's not taking any thyroid medication, right? His thyroid peroxidase antibodies used to be 523. Now they're at 506, which, isn't like 300 points less, but it is less over a shorter amount of time. And his thyroglobulin antibody used to be 24.2, and that's come down to 16. So at 5 months into it, this guy is doing pretty darn well, right? He says, I'm feeling good. I've, lost weight, even though he went on the cruise. He's lost weight. He's feeling good. Knees are feeling good. The one that was close to replacement. The TSH is normal for the first time in years, and the antibodies have decreased. So that's good. Like, that is a really good result for a guy who was diagnosed with Hashimoto's, 10 years ago, 11 years ago, then morphed into Graves' disease, right? But then, after having the diagnosis of Graves' disease, his TSH was so low, even if he didn't take levothyroxine, it was still really, really low. But the other numbers didn't really show an active hyperthyroid. Basically, what all that was telling you is this guy's immune system is unregulated. His thyroid autoimmune problem, kind of the umbrella, the autoimmune thyroid disease, was just not regulated. And so I show you this case to let you know that even with things that seem complicated, some of the same rules apply, right? We still had to analyze his immune system to find out what is his immune system fingerprint, right? He still had to avoid certain foods that he wasn't avoiding. And so if you are in this situation where your Hashimoto's is not stable and your medications having to be adjusted up and down, or you're getting hyperthyroid symptoms, most of it's explainable if you are working with a doctor that understands all that stuff. So make sure you're working with a doctor that knows the difference between Hashimoto's and Graves', how they can morph, knows how to do the right test, right? What lab test do we do to get a look at what your thyroid is doing, what your immune system is doing? How do I interpret those tests? And what I do for treatment, and how do I find out if it's working, right? Just make sure you're working with someone that is current and modern, understands all that stuff. And even if you got Hashimoto's and it turns into Graves', there's still things you can do for it, just like this guy right here. So I hope you found today's case helpful, and I'll see you next time.